So thank you all for coming. I'm Dr. Barbara Connolly. I'm a movement disorder specialist out of Hamilton General Hospital, and we're really looking forward to this event. We had almost the same event this morning for healthcare professionals, and it went over quite well, so I really hope that you guys can take something away from it today. And as I'm sure you all know very well, Parkinson's is a very diverse condition, and there's a lot of different symptoms and strategies that are necessary to help people live their best life with Parkinson's. So hope we can give you some good information today for that. I'm going to start off by introducing my colleague, Dr. Rick Paulseth. Dr. Paulseth did his medical training at Western University and then a fellowship in movement disorders and neuropharmacology in Chicago. He is a clinical associate professor in the Department of Medicine based at Hamilton General and has a special interest in movement disorders and multiple sclerosis. He's going to be talking today about diagnosing Parkinson's disease. Thank you very much. Oh, and I should actually have said that. Would you mind putting that back? I think that I forgot that I had to say that in the afternoon as well. So this is most lectures and talks these days start with this paragraph. So we would like to begin by acknowledging that the land on which we gather is the traditional territory of the Haudenosaunee and Anishinaabeg. This territory is covered by the Upper Canada Treaties, is within the lands protected by the Dish with One Spoon Wampum Agreement, and is directly adjacent to Haldimand Treaty Territory.
Well, good afternoon. I've been given the topic of diagnosis, but I thought before we launch into that, I'd just say a little bit of an overview of the disease, although probably most of you know quite a bit about it already. So it's a common disease, prevalence 200 per 100,000. By the time you're age 70, about 1% of us will get Parkinson's, and by the age of 80, about 2%. So these are the Canadian data from Statistics Canada 2014. And you can see the incidence climbs as your age increases. And the dark bar is men and the pink is women, so a little more common in men than in women. We've known for quite some time that one of the main areas affected is this movement control area, the substantia nigra, and that's that dark pigmented area in the midbrain. And in people with Parkinson's, it's not as dark. They've lost some of the dopamine-containing neurons in that region. We adjusted for someone who's about 5 feet tall, the last one this morning. So, is that better? Another pigmented neuron area that's affected is the locus ceruleus, which has to do with sleep. Underlying this, the nerve cells that are affected have these pinkish inclusions called Lewy bodies, and we'll come back to that later. So Parkinson's is named after James Parkinson. He was the son of a surgeon and apothecary in England, and he was actually quite a progressive guy. He wrote things in favor of universal suffrage before it was an in thing. He must have been a good observer of things because he described the motor manifestations, and we haven't really improved on those 200 years later. And he based that, believe it or not, on just 3 patients that he'd had and 3 people he'd seen walking outside in the street. And this is his description. Involuntary tremulous motion with lessened muscular power, in parts not in action, and even when supported with a propensity to bend the trunk forwards and to pass from a walking to a running pace, the senses and intellects being uninjured. So, when we want to move, we use the motor control area of our frontal lobe, and you see there that's in pink. So if I want to make a single movement to command or make a specific individual movement, chances are that's the circuitry that I call up. That's not actually what's affected in Parkinson's. It's motor control areas deeper and that underlying and influence the frontal lobes, the basal ganglia. And in particular, in Parkinson's, it's this one down here that's affected. We use these circuits mainly when we're doing repetitive things or things that have become automatic for us, or when we have to sort between several different competing movements that could accomplish the same goal. Our diagnosis is based on looking for the cardinal features: bradykinesia, meaning a slowness of movement; rigidity, a tremor at rest; trouble maintaining your posture or your balance. But in the last 20 years, more and more attention has been paid to the fact that there are non-motor things that happen as well. And some of these actually occur, in most instances, long before the motor manifestations. So you can see there the anatomic areas. The olfactory bulb has to do with smell. This, amongst other things, is involved in sleep. A bunch of autonomic things that control our blood pressure, heart rate, bladder and bowels, and so forth. Our emotions and our thinking, the diffuse neocortex. That's reflected also in these stages that Brock has drawn attention to. So it's actually stage 3 where the midbrain is affected, where the movement problem comes in. Typically before that, there's some autonomic problems, maybe constipation, alterations in sleep. It may not be recognized, though. Just a few words about causes. It seems that both environmental and genetic factors are important. About 10 to 15% of people with Parkinson's will have a first or second degree relative who is affected. This slide is probably out of date. I'm sure there's more than 9 genes. Every year it seems to keep increasing the number of genes that have been implicated. Unfortunately, so far that hasn't led to a specific one culprit and one treatment. It's mainly a factor in early onset Parkinson's, and yet one of the commonest genes, this one, LRRK2, is something that is more likely to show up in later onset. So for example, if you carry that gene, at age 59 you have a 28% chance of showing signs of Parkinson's. By the time you're 79, 74%. So it doesn't come out until later in life. These genes have controlling effects on something called synuclein, which has to do with how one nerve cell communicates with another. Also with energy metabolism, with certain proteins in the body. It's also interesting with the more widespread involvement than we realized maybe 20 years ago, that there are other potential causes as well. So gut is affected quite early. So one of the theories these days is maybe there's an inadvertent microbe that gets from your gut to your brain, or maybe alpha-synuclein travels retrograde up one of the nerves, the vagus nerve, to get to the brain. Or maybe it's something that comes in through our nostrils, the way we pick up colds and flus and so forth. Risk factors. Exposure to pesticides, well water, although that's probably just a marker of a rural environment, manganese, and possibly industrial exposures, protective factors, coffee, cigarettes, and possibly ibuprofen. So coffee, it's probably the caffeine. We don't know for sure, but there are receptors that are affected by caffeine. Cigarettes, again, I don't want to say a lot there, but actually what I'd rather show you is this, that despite the linkage of smoking maybe being protective for Parkinson's, it's still incredibly overshot by the fact that it also increases your mortality, so don't take up smoking. And once you've already got Parkinson's, there's nothing that suggests that having a cigarette is going to help you once you've already have it. This one kind of intrigues me. So ibuprofen is Advil. A lot of people take Advil. There's a little bit of inflammation in the pathology of Parkinson's, not prominent. A big study, the Nurses' Health Study, showed that your risk of getting Parkinson's if you use ibuprofen fairly regularly is less than, one would be absolutely no change, good or bad. This would be something that increases your risk a little. This would be something that decreases it. The reason that people still, I think, look on this with an eye of caution is that ibuprofen was positive, but it's in this class, non-steroidal anti-inflammatories. So the other ones like naproxen, Celebrex, diclofenac, and so forth don't seem to help, and if anything, are trending the other way. So occasionally studies just come up with fluke results. Exercise probably has a beneficial effect as well. It certainly does once you already have the disease. One study showed that for men, the highest percentage of people with activity had a 30% lower risk than people in the least active group. Oops, I thought there was another slide in there. Okay, well, actually there was. The other thing, it was another study showing in particular that vigorous exercise reduced your chances of getting Parkinson's down the road by something like 30%. However, that means that there's an association between exercise and not getting Parkinson's. It doesn't really answer whether exercise is protective, or there's something about being in the early premonitory stages of Parkinson's that makes you disinclined to exercise. I'd like to think it's beneficial because it's good for you in so many other ways. As a result of this knowledge about other anatomic areas being involved, the search is on for earlier signs that might permit earlier diagnosis. Especially this will be helpful if we actually do have something that does work for prevention. So loss of smell and taste can be affected early. Autonomic control problems like constipation, erectile problems, low blood pressure, feeling faint when you stand up. Anxiety and depression, obviously that's not specific to Parkinson's, but seems to often predate the illness. You can't base your diagnosis on those things alone. Something called the REM Behavioural Disorder. So REM sleep is when we dream, and normally then we're moving our eyes, we're breathing, but other than that, we're completely motionless. People with the REM Behavioural Disorder are not motionless. They move around, they twitch, they push at their spouse, they mumble or talk. We think probably they're acting out their dreams. One of the areas that's affected anatomically has something to do with sleep control, so it all hangs together and makes sense. They found that about a third of people with Parkinson's have symptoms of this long before they show signs of Parkinson's. And it's even more striking association in the Parkinson-like syndrome called MSA, or in people who get dementia very early in their Parkinson's. On the other hand, if you have this and you don't yet have Parkinson's, does it mean you're doomed? No, but you definitely are at a higher risk and you want to be doing everything you can do to protect yourself. You can see the figures there. So at this point, it's still a clinical diagnosis. We do use imaging, but really only when there are atypical cases or more to rule out other things that can kind of look like Parkinson's, what we call mimics or Parkinson plus syndromes. We're looking for a slowness of movement, so also that movements tend to block. It's hard to maintain them. You tend to lose the rhythm. People with Parkinson's don't fidget as much when they're sitting there. They often have a decrease in facial expression, in emotion in their voice, loss of arm swing when they're walking, eventually a tendency for momentum to build up so they can't put the brakes on. We call that festinating. Or their foot won't move at all. We call that freezing. Rigidity, so that's when the physician is moving your limb around. Hopefully you're trying to relax, and we're feeling an increased resistance there. It often has a ratchety feeling. That's called cogwheeling. The posture maintainment, or your balance, in other words, tends to be affected in Parkinson's, although it usually takes a while before this occurs. So the neurologist may test you by giving you a push forwards or backwards. They're not trying to be mean, they're just testing your balance. And these are the criteria that we use, the UK Parkinson's criteria. It looks very involved, but, and we won't go on in great detail, but it's basically we're looking for a slowness of movement plus one of the other three cardinal signs. There are a bunch of things to exclude because they could be looking like Parkinson's but not actually be Parkinson's. And one of the things that the scale also emphasizes is that your confidence in the diagnosis increases after you've had it for a while. So if you respond well to medication, it's more likely to be regular run-of-the-mill Parkinson's and not one of the mimics. Obviously, we can't tell that the first time we see you. Are there other things that show promise in diagnosing Parkinson's? They're looking for things that we can check in a blood test, but to date there really isn't anything that's practical or proven. We use imaging, as I mentioned, to rule out other things, but some imaging things that are available now is something called the dopamine transporter. This is a nuclear medicine scan. So in Parkinson's, this is the neuron containing dopamine. It's dying off. It stimulates the next cell. Dopamine is released and then retaken up by these reddish things, the transporter. As the disease progresses, you've got fewer of those around, and that can be lit up with an appropriate tag in this scan. So here's a picture of someone without Parkinson's. White and red has more activity. Red and yellow less active, so this is the symptomatic patient. This distinguishes Parkinson's from someone with essential tremor. Usually it's a fairly easy clinical diagnosis, but sometimes in older people who have a fairly severe tremor, it can be a tough distinction. What it doesn't do is enable us to distinguish Parkinson's from the Parkinson mimics. And something that kind of grabs my attention, because if things have a catchy name, it's easier to remember. So this was recently described as the swallowtail sign. So if you picture what the tail of a swallow looks like, and here's someone without Parkinson's, this isn't a standard MRI. This is done with special sequences you have to ask for, which were really actually championed at McMaster, but not in Parkinson's. It was actually in another condition. Anyway, you see dark on two sides and the whiter area in between, so that's the normal pattern. The person with the actual disease, we don't see the light streaks between the two dark ones. How useful is that going to be? I don't know. It was only described a few years ago. It looked very promising, but it really needs more study. It takes quite a few people before you really have a handle on the sensitivity and specificity of tests. So that's what I had. I'd be happy to try to answer any questions. Yes.
On the CBC several times there's been that program about the lady that could sniff Parkinson's prior to her husband having it. And she was in a room, with other patients, and she said, and talking to a doctor that was over to a conference on Friday, he said that they are training dogs in England just like airport use to sniff out the smell of Parkinson's long before any of the things you mentioned show up.
Okay, I didn't see that one. That's very fascinating. I really have no idea what the thing they're smelling would be. I just make the comment that chances are the spouse has a much better sense of smell than the husband, but I'm not sure that there's something specific. Can any of my colleagues help me out there? Mm-hmm.
Is there a relationship between genetic injury at a young age and the development of Parkinson's at later age?
So the question was whether there's an association between trauma to the brain and later development of Parkinson's. A very severe major head injury can cause damage, dysfunction that amongst other things can look a little Parkinson-like, but that's not really what you're alluding to here. Repeated head trauma certainly can cause a Parkinsonian syndrome, often with cognitive impairment as well. The example often held up would be Muhammad Ali. There was a twin study quite a few years ago that showed that it didn't necessarily require multiple or severe injuries, but there was a slightly higher, when you have one twin with the same genes, identical twins, one twin gets the disease, the other doesn't. There was a somewhat higher incidence of head injury in the twin who'd had head injury as opposed to the other. Okay. Well, there's a number of gut things that occur, and people with Parkinson's often have constipation ahead of time. So if they have a lot of gut inertia, they may be having other issues and be disinclined to eat as much. There's also certainly some patients, though, who come in very overweight because they've been getting less and less physically active. It's certainly not uniform. Yeah. Yeah. So the question is about Lewy bodies. So the slide that I showed shows what a Lewy body is. It contains accumulation of that protein called synuclein that was one of the things that's affected genetically in some people with Parkinson's. In Parkinson's disease, there's a few areas, the substantia nigra, the locus ceruleus, where there are Lewy bodies. In people with so-called Lewy body disease or dementia with Lewy bodies, they have those areas, but also much more widespread involvement in the cerebral cortex. And there are shades in between. So we tend to use the term Lewy body disease if the dementia and the movement problems occur together or within a year or so of each other. If the dementia, which doesn't happen in everybody, but some cognitive impairment is very common in Parkinson's. If it happens many years later, it's probably not this so-called Lewy body. Yes.
Can you just reiterate what you think of the fact that there's now saying that it is hereditary, Parkinson's is hereditary?
Well, this one slide that I showed suggests it's probably a combination of genetic and environmental things. In early onset Parkinson's, like below the age of 40, there's a fairly high incidence of it being strictly genetically inclined or caused. In most cases where it comes on later in life, there isn't a strong family history. You know, there may be some genes like the LRRK2 that makes you a little more vulnerable, but not for sure you're going to get it. And in that instance, there probably requires some combination of environmental something, be it pesticides, be it bumps on the head, be it lack of coffee, cigarettes, and exercise, and it comes together years later. But so it's not strongly inherited, but there are some instances where it is.